Adult CPR. So as you probably remember from every CPR training you've done in the past, if you've had CPR before, the first thing you want to do is assess the scene. You want to make sure the scene is safe before you even approach. Of course, if the scene is not safe, you want to make it safe. Usually this is going to require calling for additional resources. Could be the fire department if there's something on fire, a hazmat crew if there's something that could possibly be poisonous, things like that. Call for whoever you need to make the scene safe. Dog catcher, whatever is needed. Then, as far as your own protection, when you're doing CPR, you really want a pair of gloves at a minimum, but it's ideal to also have something to protect your eyes. So that could be goggles or some sort of glasses to protect your eyes. And then we also are going to be giving breaths to the patient. We want some way to protect our airway. So on your ambulance, that's probably going to be a bag valve mask or a BVM. Or if we are in the field, we may have a pocket mask. So now, what if you don't have a BVM or a pocket mask? Well, first of all, if you're on duty as an EMT, part of your responsibility is to have the equipment that you need. So if you're working or volunteering as an EMT, don't get yourself in this situation. Make sure that you do have that pocket mask or that BVM that you might need. But let's say you're off duty and you're at the mall or something like that, and you don't have a pocket mask. Keep in mind that you can do a ton of good for your patient by doing hands-only CPR, by just only performing the chest compressions. And this is particularly true with adults who need CPR. So if if you don't have that airway protection and you're not comfortable giving breaths to that person because you don't know their medical history, just feel free to only do those chest compressions. One thing to keep in mind, if you do know that person's medical history and you're not worried about catching diseases, if you want to give them straight mouth to mouth, you can do that by pinching their nose, sealing your lips around their lips, and then tilting their head to open the airway, the same way we're going to do with the BVM or the pocket mask. So it is possible. As far as how much germ sharing is going to happen there, it's about the equivalent of sharing a drink with somebody. So if it's somebody that you would drink after them, I would say that you should go ahead and do mouth to mouth on them. Um, there is always the possibility that they could vomit. So keep that in mind that you could end up with vomit in your mouth, which, sorry if that grosses you out, but it's just part of CPR. Okay, so now you've made sure the scene is safe and you have your personal protective equipment on. The next thing we need to determine is whether this person actually needs CPR. Now, CPR is for anybody who's in cardiac arrest. But people get these terms mixed up a lot, cardiac arrest and heart attack. Lay people commonly use these terms interchangeably. They'll say, oh, my, such and such family member, they died of a heart attack. Yeah, they died of cardiac arrest. Well, they're not technically wrong, but cardiac arrest and heart attack don't mean the same thing. Cardiac arrest is when the heart stops beating. What that means is that the heart is not pumping blood around the body. It's not circulating blood. Whereas a heart attack, as we know, or as you may be learning soon, a heart attack is when there is some sort of damage to the heart, is how we put it in layman's terms. So commonly it's caused by something like a blood clot in the heart that is blocking blood flow to part of the heart. So part of that heart tissue is not getting blood supply, and that part of the heart tissue starts to die. So that would be something that would cause a heart attack. So cardiac arrest could occur as a result of a heart attack. If someone has a really bad heart attack and so much of their heart is damaged that it can no longer pump blood, that may cause them to go into cardiac arrest because their heart's no longer able to pump blood. But if somebody has a minor heart attack and only a small part of their heart is damaged, they may not go into cardiac arrest. So heart attack and cardiac arrest are not the same thing. Also, there are different types of, there are other things that can cause cardiac arrest besides a heart attack. For example, somebody who's bleeding to death is going to eventually go into cardiac arrest. Somebody who's having a really bad allergic reaction, somebody who has a severe infection, somebody that's been electrocuted or struck by lightning can go into cardiac arrest. So the takeaway from this is that CPR is not just for heart attacks. It's for anybody who's in cardiac arrest or anybody whose heart is not beating. So as we approach the patient, we want to figure out, are they in cardiac arrest? So I want to remind you of the AVPU scale. Remember, this stands for, are they alert? A stands for alert. V stands for responding to verbal stimulus. And P stands for responding to painful stimulus. And then U stands for unresponsive. If you have a person who's alert, responding to verbal stimulus or responding to painful stimulus, they're not in cardiac arrest. Cardiac arrest means they've died. So if their heart's not beating and they're not alive, they're not going to be responding to pain or responding to verbal stimulus. So as we approach the patient, we kind of want to go through that AVPU list. As we walk up, we're looking at them to see if they're just looking at me as I walk in the room. If they don't, I'll move to verbal stimulus and tap them and say, hey, are you okay? I might tap them. Maybe they have a hearing impairment or something and they don't hear me. So I'm going to tap them as well as say, hey, are you okay? If they don't respond to my verbal stimulus, now I'm going to move on to checking for a painful stimulus. Now, for painful stimulus, the American Heart Association teaches 4 different ways you can check for a painful stimulus. You can do the sternum rub where you take your knuckles and rub right in the middle of the sternum. Go ahead and try that on yourself. Take note of how painful that is. Okay. Another way you can do is to push up under the eyebrow. Now, you want to be really careful here to not actually push any pressure on their eyeball, but you're coming up under the eyebrow, you're kind of digging your thumb in and then pushing back out this way. You're pushing towards the front. And go ahead and do that one to yourself. You'll feel there's a little nerve bundle that runs right under there, and you will get a very sharp pain. The other 2 you can do, the next one is an ear pinch. You can kind of pinch around on their earlobe. So go ahead and try that on yourself, pinch around on different parts of your ear and see how painful that is. Now, the 4th way that you can do is called a shoulder pinch, and it's to grab a hold of this trap muscle, the trapezius, and give that a good pinch. So you really want to dig your thumb and your fingers in. So go ahead and try that on yourself. Now, all 4 of those are an acceptable way to check for a painful stimulus. I personally prefer the shoulder pinch. To me, the shoulder pinch and the one where you push up under the eyebrow, those are the most painful. I don't like the eye one just because you are so close to the eyeball that I figure I teach CPR to enough people that if I ever need CPR, I don't want to get poked in the eyeball. So I'd rather not teach you that one. But if you like that one, you can do that one as well. So I call it the eye poke as a joke, but you're really not poking the eyeball. You're pushing on that nerve bundle up under the skull. And then that shoulder pinch. The sternum rub, if you are going to do the sternum rub, take note, you really need to be, almost to bare skin on just like a t-shirt or something like that. If somebody's wearing a sweatshirt or a coat and you try to do a sternal rub, there's so much cushioning, it really does not elicit hardly any pain at all. So keep that in mind if you're using the sternum rub. Make sure you are down to the t-shirt. I just don't feel very much pain with that one. I know if the person's laying down, I can use my weight and get my knuckles in there a little better than I can on myself sitting up, but it's just not very painful. Okay. So now if they respond to any of those, they do not need CPR. We will, we'll move on to checking their airway. If they're having any difficulty breathing, at that point, we would just help them breathe. That might include suctioning their airway to clear it out, using a BVM to assist with breaths, applying oxygen to that BVM, or maybe they're breathing okay, but they're just looking a little cyanotic, and we could use a non-rebreather with oxygen. But we'll maintain their airway and just kind of either wait for help to arrive if we're not on duty, or if we're on duty, we'll transport them in that state, keeping a really close eye the entire time to make sure they're maintaining that pulse that they had, or to make sure we haven't checked the pulse yet, but to make sure they continue to respond to that verbal stimulus or that painful stimulus. Okay. Now, if they don't respond to my verbal stimulus or my painful stimulus, that's when I'm going to take the opportunity to go ahead and call for additional resources. So I'm going to make sure I have my AED ready, or I'm going to send somebody to get an AED. And if I'm on duty, I'm going to call for ALS to meet me on scene. Or if I'm off duty, I'm going to call 911 at this point so I can get resources heading my way. Now, I'm ready to, I know they're not doing well because they did not respond to verbal or painful stimulus, but I don't know if they need CPR because I don't know if they're in cardiac arrest. So the next thing we need to check are the carotid pulse and the breathing. Now, if you have been trained in CPR for a long time, you know that a long, long time ago, we used to just check for breathing. And then more recently, we would just check the carotid pulse. But now we're checking those simultaneously. At the same time, you're going to feel for a pulse and check for breathing. Later in this, I'm going to demonstrate how to do that so you can get an idea of how to do those both at the same time. But we don't want to spend any more than 10 seconds to check for that pulse and breathing. If you're in that 10-second window and you're not sure if it's a pulse or you're not sure if they're breathing, you're better to err on the side of starting CPR. Now, if you start chest compressions and they wake up, you should definitely stop chest compressions. But if we're not sure, it's better to go ahead and start. Now, when you're checking breathing, be careful that you don't get tricked by what's called agonal respiration. Sometimes it's called the death breath, but it's this gasping that happens when someone's in cardiac arrest and they've died. The brain basically sends a signal to the muscles of breathing, the diaphragm, all the intercostal muscles, and it's basically a muscle spasm. And it's especially the diaphragm. You'll see the belly moving a lot, and you'll hear a gasping sound. And that is not true breathing. They're not really moving enough air in and out to actually be breathing. It's just kind of a response that happens. It's just a final signal that the brain sends. So if they have that gasping, that's not true breathing, and you should start CPR anyway. Now, as a special circumstance here, we usually check the pulse for 10 seconds. But if the person's hypothermic, so if they've been in cold water or if they've been outside, remember most hypothermia cases happen between 30 and 50 degrees Fahrenheit. So it's not that cold of a day, at least here in Montana, that's not that cold. But if they've, been outside, or even if they're inside, but their house is not heated very well, if they feel cold to the touch, go ahead and feel that pulse for a full 60 seconds, because someone with hypothermia can have a really, really slow pulse. So if you only wait 10 seconds, you may miss the pulse that actually is still there. If they have any pulse at all in an adult, we're not going to start CPR. Okay, so once we've determined that they're not responding to painful stimulus and they don't have a pulse and they're not breathing, we already have help on the way. We have somebody bringing us the AED. We're ready to start chest compressions. To do those chest compressions effectively, we want to make sure our patient is on a nice, firm surface. We're going to place the palm of our hands. We're going to use the heel of our palm in the middle of their sternum, right between the nipple line, and it's where their nipples would normally be. So if they have nipples that are lower than what they might have been at one time, we're going to ignore that, and we're going to do those chest compressions right where you would imagine the nipples are supposed to be. You're going to lock your elbows so that you're not using your arms, but you're actually bending at the waist and using your body weight to do those chest compressions. And then adequate depth for those chest compressions is at least 2 inches. So as you compress down, you want to make sure you're going down at least 2 inches, but also you want to look for good chest recoil. So as the chest comes back up, that's going to let the heart refill with blood. So when we compress down, we squeeze the blood out. When we let the chest recoil back up, that's going to let the heart refill with blood. And then the speed for this is between 100 and 120 compressions per minute. So we're going to look at 2 videos here where I demonstrate chest compressions and talk about some of these intricacies with the chest compressions. So I'll be quiet and let you watch those videos.
Okay, so excuse my headphones, they're going to help with the audio for these videos. So for chest compressions for an adult, we want to do those compressions in the middle of the chest. Now, to get our patient in a good position to do those compressions, we want them to be on a nice firm surface. So you'll notice here I have the patient in the floor. That's commonly going to be the best place. But if they're on a bed, a gurney, a couch, anything like that, they either need to be moved to the floor to do chest compressions, or as you know in the ambulance, we can slide a backboard or a CPR board underneath at least their torso so we have something firm to push against. If they're on a gurney without that backboard or a couch, as we push into them, they're basically just going to sink into the cushioning, and we're not actually going to be able to get good chest compression. So once we have them to a firm surface, we want to look at our hand placement. When you do chest compressions, you really want to use the heel of your palm. That's going to be the bottom third of your palm here. If you put your whole surface of your palm flat on the chest and try to compress down, it's really difficult to get enough of a force to compress the chest. It's going to be a lot easier to kind of center that force by using the heel of your palm. So the way we do that is we usually interlock our fingers and then we kind of bend our wrist back. So from the side, it kind of looks like this, so that I'm using just the heel of my palm. So when I'm doing these compressions, I can only feel this part of my palm making contact with the surface of the chest. So I can kind of see you can kind of see part of my palm is not touching the chest from this angle. Okay. You also notice that in addition to compressing the chest, I'm also allowing the chest to recoil with each compression. What that recoil does is allows the heart to refill with blood between compressions. So in slow motion, those compressions have two parts and they're equally important. That first part in slow motion is compress down to squeeze the blood out of the heart and send it around the body. And part two is let my weight completely off the chest so that the chest can recoil and allow that heart to refill with blood. You also notice we're going at a speed between 100 and 120 compressions per minute, also known as to the beat of staying alive, or another one bites the dust, but if you sing that one out loud, that can get a little bit awkward. So I'd suggest not singing that one out loud. So our compressions. 15, 20, 25, 26, 27, 28, 29, 30. Okay, so excuse my headphones, they're gonna help with the audio for these videos. Another thing to notice for the adult chest compressions is that you want to use your body weight. And this is going to be the case for the adult and the child chest compressions. If you try to use just your arms, you may be able to get enough force. This is going to get very tiring very quickly, and you're not going to be able to get as much force as using your body weight. So instead, we're going to get our hands placed on the chest, and then we're going to hinge at the hips and use our body weight. Notice that my arms stay locked. My elbows aren't necessarily straight, they're slightly bent, but you won't see my elbows bending and straightening as you did the first time. So my elbows will stay locked in the same bent position. And I'm using my body weight, just hinging at the hips to get those compressions. That will help me stay consistent, and it will also help me save up some energy so that I'm not working as hard to do those chest compressions. And from the side angle, have a look at that. Might be a little easier to see.
Another thing to take note of here is that the shoulders are right over the center of the chest so that that force is going straight down into the chest. If you're too far away from the patient and having to reach forward, you won't be able to use your body weight. So you want your shoulders to essentially be right over the center of the patient's chest so that those compressions, so that force is going straight down into the chest with each compression. Okay, so moving on to the breaths that we'll also be giving. To give the breaths, you want to make sure that the airway is open. Now, most of the time when we're doing CPR, we're going to be using the head tilt chin lift. That is the easier way to open the airway. If you can't use the head tilt chin lift, why would we not be able to use that? Well, that would be if the patient experienced any sort of trauma and we think they might have a head, neck, or back injury. If that's the case, we cannot use the head tilt chin lift, and you would have to use the jaw thrust maneuver to open the airway. Now, the problem with using the jaw thrust maneuver is that it takes one person just to maintain the airway. You're putting your palms on their cheeks and then pushing their jaw forward to pull the tongue out of the airway, and that requires two hands. So you can't squeeze the BBM at that point because you're holding that jaw thrust. Now, if you've already done or you're going to do our cardiovascular 2 training or the pit crew CPR training that I offer, you'll notice that in those videos, I explain how you can have the person who's doing the breaths only hold the mask, and the rescuer who's doing the compressions to squeeze the bag, so that you can have 2 rescuers, but that you can have both of them helping with breaths. That's a great solution to being able to do that jaw thrust if it's needed. But if you're completely by yourself and you're doing one rescuer CPR as we're practicing here, there's really no way to do the jaw thrust and give the breaths with a BBM. You would have to switch and use a pocket mask if that's the case. And really, anytime you can't get breaths in with a BBM, you should use a pocket mask. So once we have the airway open with that head tilt chin lift or that jaw thrust, we want to get a good seal with the mask. So we're going to take the skinny part of the mask and put that across the nose. The round part of the mask goes over the chin, or kind of between the lower lip and the chin, really. It'll just depend on the size of the person's face. And then if you have an extra person, it's best to have, as I mentioned that we did in the pit crew CPR, one person hold the mask and the other person squeeze the bag. So especially if you just have somebody that's standing around not really doing anything, you can have them squeeze that BVM so that the person on ventilations can do nothing but just secure that mask with both hands. You'll get a lot better seal that way. Delivering the breath over a period of 1 second. So when you squeeze the BVM, it needs to be slow and controlled over the period of 1 second, just until you see the chest rise up. If you continue to put more air after the chest rises, that's going to cause further harm. Some of that air is going to leak out into the thoracic cavity, and that extra pressure is going to build up and push on the heart. And that's going to make it even harder for that heart to be able to refill with blood between compressions. So you're not really able to get as good of circulation if there's too much air pressure built up in the thoracic cavity. Also, some of that extra air is going to end up into the stomach. As air builds up into the stomach and they get abdominal distension or gastric distension, they're really likely to vomit. And that then, one, that's gross. We don't want them to vomit. But more importantly, that vomit becomes an airway obstruction. Now we have to stop chest compressions, roll them on their side until they're done vomiting, scoop the vomit out of their mouth, and suction their airway. So that's going to interrupt those chest compressions. So we really don't want that for multiple reasons. You always want to limit your time off the chest. So when you're giving these breaths, it's not like rescue breathing where we give the breath every 5 to 6 seconds. This is very different. We just want to give 2 quick breaths, basically squeeze the bag over the period of 1 second. As soon as you see the chest fall down, go back to its normal position, immediately give that second breath, and then let the person start back in on chest compressions. So let's have a look at what those breaths look like in a video here.
For those breaths, we're going to use, typically we're going to be using a BVM or a bag valve mask. You may also be using a pocket mask. A pocket mask will look just like this part of the bag valve mask, the mask part, but we'll also have a little one-way valve that attaches right here. So when we're using that mask, we're going to put the skinny part is going to go on the patient's nose and the round part is going to go on the chin, like that. So we'll either have a one-way valve or we'll have our BVM that's attached. There's 2 important things to getting a good breath in. One's going to be getting a good seal on the face, but if we leave our patient supine like this, the tongue's going to fall in the back of the throat and close the airway. So we also need to open the airway, most commonly using that head tilt chin lift. Now this ties up 2 of my hands, so typically I'm going to do that head tilt chin lift with one hand on the mask and squeeze the bag with the other hand. As you can see, the patient's chest also rose. We want the chest to rise with each breath. Now for that seal, you can come from above the mask and push the forehead down, or you can come from below the chin and lift the chin up. As long as you're getting chest rise, whatever's working for you is going to be fine. If you can't get the BVM to work, you should always switch to a pocket mask. Take the mask, attach a one-way valve, or get your pocket mask out of your bag. You can use 2 hands to get the seal and then use your breath to give the breaths that way. Use your mouth. Okay? Now when we're giving those breaths, we also want to make sure we don't give too much air. As we give the breath, we're going to tilt the head, just squeeze just until we see chest rise. Just like that. So tilt the head, get a good seal on the mask, squeeze just until we see chest rise. For those.
Okay, so now putting this all together for adult CPR. We want to do our compressions and our breaths. We want to do the compressions, 30 of them, followed by 2 breaths. For CPR for an adult, it's always 30 to 2. Always 30 compressions followed by 2 breaths. 30 compressions, 2 breaths. We'll talk about different ratios that we use for children, but for adults, we always are 30 to 2 no matter how many rescuers you have. Whether you're by yourself, whether you have 2 or 3 people helping you, or 10 people on scene, it does not matter. If the patient's an adult, we always do 30 compressions and 2 breaths. Now, if you do have somebody else on scene, there are some changes we want to make. One thing is that you should swap roles. The person doing chest compression should swap out their role every so often. Now, when I ask, classes full of students, I say, when should you switch places? The most common guess is when you feel tired. And in theory, that's a great idea. However, in practice, when you're doing CPR, especially the first few times, you're going to have a ton of adrenaline pumping through your body. When you have a lot of adrenaline going and you're in that fight or flight mode, you don't really feel tired. You won't feel tired in the moment. Now, when the scenario is over and the patient's been transported off to the hospital or revived or whatever, at that point, You will feel exhausted, completely exhausted. But in the moment when you're right there doing those chest compressions, counting to 30, and everything's going on around you, you won't feel tired. If this doesn't make sense to you, think about a time when you were maybe playing in a sports game and the score was tied and you only had 1 minute left in the game, or maybe you were in a bad car accident and you had a lot of adrenaline going, or even maybe a time when you were in an argument with a family member or significant other. Right in the middle of the argument, you're not going to be like, oh, let me just sit down and rest for a minute, right? And right in the middle of the car accident, you're not like, oh, I could really use a nap right now. And right in the middle of that game, you're not like, hey, coach, take me out. I need a break, right? When the game's over or the accident's over, then you feel tired. So the same thing's going to happen in the middle of doing CPR. You won't really feel that exhaustion, but that doesn't mean your muscles aren't getting tired. Your muscles are starting to get deprived of the oxygen and nutrients that they need after that 2 minutes of CPR. So it's best that you switch places. I already gave you the answer, about every 2 minutes. 2 minutes is just where, when they've studied multiple people doing CPR, that's when they start to see the effectiveness of their compressions starts to decrease. I see this in my class too. I have an iPad that connects to the mannequin for students to do CPR. And it's like when they get to that 2 minute mark, their speed or their depth, something always starts to really get kind of wonky at that 2 minute mark. Now, keeping track of 2 minutes may be a little bit difficult. So another way you can keep track of when you should swap, 2 minutes falls about every 5 cycles of CPR. A cycle is 30 compressions followed by 2 breaths. So once you've done 30 compressions and 2 breaths 5 times through, once you've given those 2 breaths for the fifth time, that is when you should trade places. Another thing to keep in mind when you're doing two-person CPR is that we can make everything more efficient. If you're the person doing chest compressions, when you finish your 30 chest compressions, you don't want to sit back and relax and wait for the breaths. You actually want to stay hovering right over top of the chest so that you can get back onto those chest compressions immediately. Same thing goes for the person giving the breaths. If you're the person ventilating the patient during CPR, get that CE clamp on the mask, get that head tilt chin lift. When you hear 28, 29, 30, you're going to squeeze the bag 2 times to give the 2 breaths, and then you're going to maintain that seal with the mask. So you're going to hold the head tilt chin lift, you're going to hold the mask over the face, and you're going to keep that seal so that when they get to 30 again, you're ready to give those breaths without any lapse in time of trying to get everything in position. Once you know you get the breaths in, hold that position because you know it'll work every time. Sometimes people ask me, well, do you really want to keep the mask over the face because now they can't really exhale? Yeah, in fact, if the BVM is attached to oxygen, it's even going to help them get a little bit more blow by oxygen as you do those compressions. If any air is coming in and out of the mouth and nose, it'll be more oxygenated because it's attached to that BVM. So I would definitely suggest keeping that head tilt chin lift in place, keeping the mask over the face, and being ready to give those compressions when it's time. The other thing is, if you're the person doing chest compressions, make sure you count out loud. You'll see that in the video we're going to watch in a second. You don't have to count every single compression out loud, but every, maybe 10, 15, 20, let them know about where you're at. And then from 25 to 30, make sure you count each one out loud so that the person giving breaths knows, okay, it's almost time to give these breaths. Now, when should you apply the AED? So those of you that are going to take or have taken the National Registry test for CPR and AED, you might recall or notice that you have to do 2 full minutes of CPR during the test, and then you apply the AED. But you should also take note that during that test, the AED does not arrive until you finish those 2 minutes of CPR. And that's just because the National Registry wants you to be tested on CPR and AED use. So they don't want the AED to show up right away because then we wouldn't get to test you on CPR. So in real life, when should you apply the AED? As soon as it arrives. If you have the AED right there with you, I would turn it on, do chest compressions while it gets ready to talk to you. And then as soon as it tells you what to do, stop your compressions, apply that AED, and then get right back to those compressions until it tells you to stop. If you have 2 people in the field, as you commonly will in an ambulance, one person should go straight to chest compressions while the other person gets the AED out of the bag, turns it on and all that. And you can continue CPR while that other person works around you to apply the AED. So in the video here, you're going to see that I actually have to stop CPR to apply the AED, but that's because I'm doing one rescuer CPR. As soon as that AED arrives, I'm going to stop and apply that AED. Now, another thing with the AED is that it is going to shock the patient every 2 minutes. Shouldn't say shock, but it's going to analyze the patient and, if needed, deliver a shock every 2 minutes. Remember what else we're doing every 2 minutes? That's right, we're trading places with the compressor. So another good way to keep track of that 2 minutes, if you have an AED on scene, the first time that AED analyzes and shocks, go ahead and swap out compressors. There's a lot of downtime between while the AED is analyzing, charging, and shocking that nobody can touch the patient anyway. So that's a great time for somebody new to get into position for those compressions. And then that way, the next time it shocks, you'll know it's been 2 minutes. Excuse me. The next time it analyzes, you'll know it's been 2 minutes, and that'll be time to switch again. So just keep those switches in tune with the AED shocks. So let's have a look at this.
This all together into the full, basically, scene of you come up to someone who's unresponsive, checking to see if they need CPR and performing CPR. So I've just arrived on scene. Hopefully I have my personal protective equipment on. My scene looks safe. I'm now approaching the patient and checking for a verbal stimulus. Hey, are you okay? Okay. If they do not respond, I'll move to checking for a painful stimulus. I prefer the shoulder pinch, so I'm going to pinch the trap muscle. Sir, can you hear me? Okay, if they still do not respond at this point, they're fully unresponsive, I'm going to go ahead and call for ALS, or if I'm not on duty, I'm going to call 911, and I'm going to call for an AED. So I have ALS, 911, AED heading my way. Now I still need to check to see if this person needs CPR. So I don't know if they have a pulse. So I'm going to check pulse and breathing at the same time. Notice when I'm checking pulse, I'm checking the carotid pulse, and when I'm checking for breathing, I have the airway open, and I have my head down next to the patient. I'm listening for any air movement out of the mouth and nose, feeling for any air movement out of the mouth and nose, and also watching for chest rise. Okay, I'm going to check for up to 10 seconds. I have no pulse, no breathing, starting CPR. 10, 15, 20, 25, 26, 27, 28, 29, 30. Breath, right back to chest compressions. 10, 15, 20, 25, 26, 27, 28, 29, 30. 2 more breaths. And I will continue this until my AED arrives. Okay, let's say the AED just arrived. I'm going to turn it on. It's going to talk to me and tell me my instructions.
Apply pads to patient's bare chest.
Okay, I need to apply the pads.
Pads connector next to
do that right
flashing
away.
light.
Applying the pads. Upper right, lower
Apply
left.
pads. Plug in
connector.
connector. Analyzing
Okay,
heart
it's analyzing, so we're all going to stand clear.
Do not touch the patient. Shock advised.
Okay, shock advised. We're going to continue to stand clear.
Charging. Stay clear of patient. Deliver
Okay,
shock
all clear,
now.
shocking.
Press the
Shock delivered, continuing CPR.
Begin CPR.
Okay, and then just a couple other things you might come across, something else you might come across when you're doing CPR, when you're working with a team. If you have a paramedic on your team or somebody with airway endorsements, they may be placing an advanced airway in the patient. And a couple of things will change with CPR at that point. So an advanced airway would be that they had been intubated. There's also other devices out there like the King Airways or the iGel. The way that you'll know they've been intubated, first of all, you'll see the paramedic doing it, or you'll arrive on scene, and maybe it's already happened. If that's the case, you'll see a tube sticking out of the patient's mouth. That will let you know, okay, this patient has an advanced airway, and CPR is going to change a little bit. First of all, for your BVM, your bag valve mask, you're going to actually remove the mask, and the part that usually plugs into the mask will now plug directly into the tube coming out of the person's mouth. Now, luckily, these things are all universal. It's not like an iPhone, Android, what kind of charger do we need? No, there's none of that crap going on. it's always going to match. They're all made to fit each other, even if they're different brands. So you'll be able to remove the mask from your BVM and then attach your BVM directly to that tube coming out of the patient's mouth. But there are some other changes as well. Typically, we have to stop chest compressions to give those breaths because we're compressing on the chest and it would be really difficult to get those compressions in. However, when they have the advanced airway in, that tube is going down the trachea, down further into the airway towards the lungs. Because of that, we can actually continue with compressions. We don't have to stop the compressions to give the breaths. So if you're doing the compressions and they have an advanced airway in, there's no need to stop every 30 compressions. Just keep going. Now, it is common that if you're doing those compressions, that you'll still count the number of compressions, and you'll count all the way up to 200. Remember, we're doing 100 to 120 compressions a minute. So when you get to the 200 mark, you're basically really close to that 2-minute time limit, and you should be swapping out with somebody else to do compressions. Also, if you have a paramedic on scene, they may ask you to stop CPR at this point to recheck the pulse because it's been 2 minutes. Now, if a paramedic is not there and you're only a BLS crew, you should never stop CPR to check a pulse. Once you've started CPR, and this doesn't matter if they have an advanced airway in or not, once you start CPR, you only stop if you see signs of life. So we'll talk a little bit more about that later, but just keep in mind, you don't do a pulse check. Even after the AED shocks, even after 2 minutes of CPR, you never stop CPR to check a pulse unless you just arrived on scene. When you first get there, you're going to check for pulselessness. And then after that, you just assume they don't have a pulse and continue those chest compressions. It's not worth that lapse in chest compressions to check the pulse. So just keep doing the chest compressions and don't stop. Now, so back to that advanced airway. If they have that advanced airway in, you'll do those continuous chest compressions. And the person giving breaths, instead of counting 30 compressions, they're going to go to what we usually do for rescue breathing, which is just to give that adult patient a breath every 5 to 6 seconds. So this can be a little bit tricky if you're on breaths because the person giving compressions, remember, they're going 100 to 120 a minute. So they're giving possibly 2 compressions per second. So if you count 6 compressions, that's going to be way too fast on the breaths. So I'd really suggest watching your wristwatch, or counting out loud: 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, 6 Mississippi, breath. Or 1 1000, 2 1000, 3 1000, 4 1000, 5 1000, 6 1000, breath. Right? About every 5 to 6 seconds. If you count to 6 seconds, you'll probably be closer because most people count a little bit too fast. So try to time those breaths between 2 compressions as best you can, but it's not like there's going to be a 1 second gap between the compressions. So kind of just give them every 5 to 6 seconds. Okay, I'll see you in the next video. Thank you.